Welcome, everyone. I'm Dr. Constantinides. We're going to talk about blepharoplasty today. Um, I'll start in order to stay on time. It'll be about 30 minutes, and there'll be options for questions at the end. Now, in order to ask a question, if you look at the quick Q&A button at the bottom or on your screen, you can click that button. It'll open a box, and you can type a question, and at the end, we'll go over those questions and answer them as much as we can. With me is Devin Wright. Devin is my cosmetic consultant, and Devin will be your point person for any, further action that you might decide to take regarding blepharoplasty with me. Let me get my screen shared so we can start our presentation. All right, so blepharoplasty unveiled. I'm Minas Constantinides. I work at Westlake Dermatology at Lamar Central, one of our many locations. I'm double board certified in facial plastic surgery and in otolaryngology or ear, nose, and throat surgery. And why are you looking tired all the time? So here's a little short bio. I'd like to just mention, other than my education, which is the top here, these 10 years I was director of facial plastic surgery in the Department of Otolaryngology, the ear, nose, and throat department at NYU Langone Medical Center in New York. I got to Austin 10 years ago. After a career of running education in facial plastic surgery at NYU, and being very active nationally in the facial plastic surgery scene. I still am pretty active. I came to Austin 10 years ago just to find a place where I could slow down a little bit and enjoy the weather and enjoy the people. And I've just loved it. The transition to Austin has been amazing, and I cannot tell you what a positive change it's been for both me and my family. When I got here, I was founding president of the South Texas Society for Facial Plastic Surgeons. I'm really proud of that. It's a group of like-minded surgeons who basically get together and talk about clinical issues or practice-related issues, and it's just been fabulous. So let's talk about what happens as we age. And so the anatomy is pretty straightforward. We're going to talk about lower lid here first. Lower lid anatomy, when we're young, there's a strong muscle belly called the orbicularis oculi that is held back in position by the orbital septum, also called the orbicularis retaining ligament. And that ligament inserts in front of the bone here of the maxilla, the cheekbone. And then below that is the cheek fat. So as we get older, this muscle and ligament tends to bulge, tends to allow bulging forward of eyelid fat, and that's what creates the bag. But the tear trough, or the crease below the bag, is created by this insertion of the ligament. So and then other things happen, like we lose some fat volume in the deep compartment of the cheek, and then we might lose some bony mass in below the eyelid. So all these things contribute to having a sagging effect on the tissues around the eye and allow for orbital fat or the eyelid fat to bulge forward. So surgery is intended to improve all that. So going back to this woman, what happens as we age, and we'll talk about her outcome after surgery closer to the end of the talk. But the first thing that happens is the tear trough deepens. And this ligament, the orbital septum, limits how far the fat can descend because of that tear trough insertion. So we get a sharp delineation of the fat as it bulges forward. And like we talked about, the malar fat pad, or the deep fat pad of the cheek, also can descend, and we can lose bony volume in the cheek. What this does is create a lengthening of the shape of the appearance of the eyelid. The muscle weakens, the fat bulges forward, and the eyelid looks longer, and the skin itself can get more wrinkly as we lose some of the elastin and collagen in the skin. So and we'll talk about this muscle lengthening, this eyelid lengthening concept a little bit in a little bit. Upper eyelid, kind of similar things happen. Eyebrow, first of all, can descend. That creates hooding or heaviness of the upper eyelid. The fat sometimes can bulge forward. That's deep in the eyelid, just like the fat in the lower eyelid can bulge, so can the upper eyelid fat. The skin becomes looser, but the muscle underneath really does not become looser. And so treatment is intended to treat skin laxity, the looseness in the skin, to treat eyebrow position if it's required, and then to also treat any bulging fat. Ptosis can occur. Ptosis is actually a descent of the eyelid margin downward. This young lady has some ptosis. The eyelid margin has fallen closer to her eye, to her pupil. And when ptosis is severe enough, it can obstruct vision. The other reason that ptosis occurs is the heaviness of the eyelid skin can weight down the eyelid. And so the treatment is different for ptosis not due to weighing down and ptosis from weighing down. The ptosis from not weighing down is because of this structure, the levator aponeurosis that lifts her eyelid can stretch out. So these are other things that we can improve with surgery. So let's talk about upper eyelids first. This is a young lady who didn't like the heaviness of her upper eyelid. She's in her mid to late 40s, and she has heaviness here. Her eyebrows have come down a little bit from where they were. As she smiles, you can see her wrinkling of her skin, of her lower eyelid, but her lower eyelid really doesn't have any fat bulging. It's really just a skin wrinkling problem. And so what I did was an upper blepharoplasty and a deep chemical peel to try to tighten some of this loose eyelid skin. We did not, we decided to leave her eyebrows where they were and just remove the extra skin that was weighing her upper eyelids down. The header peel is a deep peel that can help to improve the wrinkling of the eyelids. So if you look at her when she smiles now, her eyes look more open and she has less wrinkling. Now, of course, we did some Botox as well to enhance the wrinkling that can't be smoothed with peeling. So just controlling and softening the muscle pull and muscle function can help keep the eyes open with smiling. Close-ups show before and after how just removing extra skin can unweight the eyelid and cause it to look more open, and then tightening the eyelid skin with a peel can help smoothing. There are lots of ways to tighten the eyelid skin. Some surgeons like lasers, others like peels. I like peels. They're sort of one and done, and we don't need to worry about doing it again. As she's looking sort of down at the camera, we can see the incision lines are really pretty hard to spot, and she has a nice smooth shape to her upper eyelid area, and of course all the wrinkling of the lower lid is seen improved. Here's another patient with age-related changes. Eyebrow positions come down, heaviness of the upper eyelid, her lower eyelid fat bulging, the tear trough is deepened because of that ligament insertion, and she has also lost some volume in her midface. You can see that midface coming down. There's a ligament here called the malar ligament that separates this fat pad, the malar fat pad, from the SUF, the suborbital suborbicular fat pad. The reason that it's important to notice this is that this ligament and these fat pads, in particular, this fat pad will fall down and back as we get older, and this fat pad falls forward. And so it creates a space, and this ligament becomes deeper. And so it's something that we pay attention to with surgery if we can improve it. Before and after surgery, this is 18 months after endoscopic brow lift. upper and lower blepharoplasty, and a lighter peel, a medium Jesner's TCA peel. And so we can see eyebrow position has been improved through the endoscopic brow lift is done through 4 incisions, 2 sort of where we want the maximal pull to be with the eyelid, and 2 more laterally. And through those 4 really pretty small incisions, we can release and access the whole eyebrow area, a whole forehead and eyebrow area, and we can place the eyebrows where they were when she was younger. Now she still has a little bit of excess to her eyelid skin, and so we'll remove that at the same time. The lower lid, transconjunctival lower blepharoplasty. Through the eyelid, through the back of the eyelid, we can come over the fat pad, release the ligament so that the fat in the cheek can rise. We can lift the fat pad up in the cheek to create a smoother transition between eyelid and cheek and smoothen this fat back. So an important distinction about how I do lower blepharoplasty is that I prefer to go from the inside of the eyelid. I don't like going from the outside. I don't like a potential scar underneath the eyelashes, although these scars are quite hard to spot in most patients. When they don't heal well, it's a real problem. The going from the inside also helps to maintain strength in the eyelid so that the eyelid is less likely to droop downwards as it heals. And we'll talk about the phases of healing in a little bit. But eyelid strength preservation is super important with eyelid surgery so that the eyelids themselves stay in the same position and they don't pull down or cause malposition of the eyelid. So smoother, more natural, but really supernatural look, and she's super happy when she smiles. The crinkling is controlled with Botox typically, but the eyelid position looks so much better, and her eyes just pop still when she smiles. Beautiful, snatched look, like they like to say now on TikTok. The close-ups show all those same changes. Eyelid heaviness improved of the upper lid, and the fat improvement of the lower lid with this release and movement of cheek fat up to where it was. Some surgeons like to take this eyelid fat and position it into this tear trough. That's called fat transposition blepharoplasty. I prefer not to do that. I like to take some of this fat out and then lift the cheek up so that your natural fat will fill that area. Now, in patients with real deficient fat, then we might have to add some fat from elsewhere. But in general, that procedure does really, really well. Here's the improvement in eyelid length that we talked about earlier. So an older eyelid, the eyelid looks long because of what's happening between the eyelid margin and the tear trough. All this bulging and indentions here creates a long, unattractive eyelid. Eyelid surgery should create a shorter appearance to the eyelid, so it looks no longer looks that long, but looks nice and short. If you look at younger colleagues or younger people, they all have short-looking lower eyelids. The eyelid itself doesn't look like it goes all the way down to here, which is one of the reasons I think the eyes look older. So this is what we just talked about, transconjunctival approach, which is from the inside of the eyelid. I go between the muscle and the fat. So the muscle is this orbicularis oculi muscle that I dissect down between that and the eyelid fat. And then we come down to the insertion of the septum, release that insertion. So now we're dissecting and releasing into the midface. And then we'll take out whatever fat is extra, raise the cheek so that it fills the tear trough and creates a shorter look to the eyelid and also more support to the eyelid, so it doesn't tend to pull down as much. And then I look at this transition between cheek and eyelid, and if it's not perfect, I might put back some of that eyelid fat. That fat, when we remove it and put it back like that, it stays forever. We close with dissolvable stitches that are on the inside of the eyelid, so they don't have to be removed. And then typically we'll do a peel of some sort. As she looks up to sort of put tension on the area, we can see the nice transition between cheek and eyelid on both sides. Another another younger woman in her mid 40s with who I did an upper and lower blepharoplasty. Now, if you look at eyebrows here, you'd say, well, why didn't I do a brow lift? And why, in fact, does she look like her eyebrows are higher? And that's the result from Botox. So we decided that we just want to take off the extra skin that she had and improve the fat bags of her lower lids. We see this beautiful transition now between cheek and eyelid with all the techniques that we just talked about and softening and the natural look, a very natural look to her upper eyelids. When she smiles, Botox has controlled the wrinkling, but also that medium Jesner's TCA peel. JTCA peel helps to smoothen the skin further, and her eyes just look beautifully open and when she smiles. Oblique views just to try to demonstrate in other angles what happens with all these changes. Obviously, the eyelid itself goes from long to short looking. The transition between cheek and eyelid is soft and natural, and now the fat is higher in her cheek. If you look at her cheek fat here compared to here, we've lifted it so that now we have a beautiful sort of filling of this upper cheek eyelid transition, which looks gorgeous. When she smiles, again, all the same things that we just talked about, a beautiful, natural look to her eyes and smile. And she no longer looks tired. Three-quarter view smile, and then close-ups. Looking up views are helpful to sort of put things on stretch and see where the changes have been made. And we see this beautiful smoothened lower lid, the beautiful shadowing between eyelid and cheek that isn't sharp anymore. It's just a smooth transition and a gorgeous look to her midface. We'll look at her upper eyelid incisions. They look beautiful, hard to find. And here's that first patient that we saw before and after lower blepharoplasty. Sorry. Just move this. So we did upper and lower blepharoplasty with now in this case I did perform did make an incision underneath her eyelids, and the reason is that she actually had extra skin. Usually patients don't have extra skin. All the other patients we saw did not have extra skin. They looked like they would when they smiled and crinkling, but it's not extra. It's just wrinkly. Here, there's actually extra because of how big her bags are. It's created this very heavy skin that actually looks like it's extra. So in order to improve that, lower blepharoplasty from the outside now, because we will release and lift the eyelid a bit and lift the midface as well so that we unweight the eyelid, shorten it, and create improvement. Upper lid blepharoplasty with fat removal. And then I did an endoscopic brow lift for her because she had so much heaviness here that it just intended to unweight the eyelid. It wasn't really to raise the brows as much. Of course, she doesn't look as angry. Things are improved with the endoscopic brow lift because the brow position's a little bit better, but mostly it's for stabilizing the brow so it doesn't tend to pull down after upper eyelid surgery. Close-ups showing nice improvement in transitions and everything else with smoother skin. No peel done on this patient. And really nice improvement to transition between cheek and eyelid. Men can benefit from all this. This is a man in his mid-30s who always felt tired, or always felt like he looked tired, and transconj lower bleph, the same exact technique that we just talked about, gives a real natural appearance, and that tired look is gone. Super happy with that. And stressing the eyelid fat, we see really nice smoothness now between cheek and eyelid. Here's an upper and lower blepharoplasty without brow lift and a deep peel. Deep peel, a lot of wrinkling. So we choose to peel deeply so we can smoothen as much as we can. Downside with peeling deeply all the time is that the deep peel takes a lot longer to heal, but the results are outstanding. So improvement of the contour of the upper lid, transition from cheek to eyelid is better, eyelids look shorter, and now the skin smoothing is much, much improved. Close-ups demonstrate that improvement, a real natural look. And then another patient with just a lot of extra skin. So I do make an incision at times underneath the eyelashes when there's extra skin, but 90% of patients don't need that incision. upper blepharoplasty to unweight the upper lids and open her eyes up and make her look a little bit better. Not as tired looking, looks supernatural, friendlier, more rested. Sometimes we have to do a more extensive midface elevation. And so in this patient, for example, she had all the things we've been talking about, but some deficiency to her midface. And so it wouldn't have been enough for me to just release a little bit and bring this cheek fat up. So I had to do a more complete midface release also through the eyelid approach. So eyelid approach, midface release, and then lift up the midface with sutures to elevate the cheek position. You can see a nice elevation of cheek position after compared to before, and then smoothing out the fat transitions. So nice improvements, and she looks more rested and much better. And another example of where the midface lift is really helpful. So this patient has these deep malar ligaments that separate the malar fat pad from the SOOF, and then heavy fat pads. So midface anterior blepharoplasty to be able to do a very complete midface release. We can now do this from the inside of the eyelid too, but in this case I decided to go from the outside. We come down, release and lift the midface. So now all the ligament problems that we see are much improved. So smooth transitions, she looks natural, doesn't eyes look great and very engaging. The midface elevation also helps support the eyelid so that the tendency to pull down during healing is supported and tends not to happen as much. Risks of blepharoplasty, blindness is been reported in 1 in 25,000 patients. Now this is a real concern. Why would patients get blind after blepharoplasty? Well, the reason usually has to do with bleeding into the back of the eye. So if there's uncontrolled bleeding into the back of the eye, can cause pressure on the optic nerve, and if it went untreated, would lead to blindness. Now, let's knock wood. This has never happened to me in my practice, but I have saved some eyes when I was in New York working on trauma patients where they had that kind of bleeding, and we went in and were able to save the eyes. So we always warn patients, if you have decreasing vision and increasing pain in one eye, that's something to wake me up about. But fortunately, that's never happened. Just trying to be super vigilant about every little bleeding point during surgery so that we don't have bleeding afterwards. Injury to extraocular muscle. We see these muscles at the time of the surgery. If one were injured, you wouldn't be able to, you'd have double vision. It would require further surgery by a different kind of surgeon. This has never happened in my practice again. but it's something that we're watchful for. We want to protect, identify and protect these muscles during surgery. Corneal injury happens when the eyelid, when the cornea, the eyeball gets dry, typically during eyelid surgery. We protect the eye with special thick contact lenses called corneal shields during surgery, but even with those, sometimes there'll be some dryness underneath and patients will get irritation. The treatment is closing the eye, and I'll tell you how we do that for all our patients for a reason, and then some steroid drops, and then it always gets better. Chemosis is swelling of the conjunctiva. It can occur in many patients, especially if we're doing extensive surgery around the eye, say if we're doing an extensive midface lift, or if we're doing a facelift at the same time as blepharoplasty, can cause swelling of the white of the eye, which is called chemosis. It always goes away. We give a steroid drop and it gets better. Lower eyelid malposition, eyelid pulls down during healing. That's something we're really vigilant about and can intervene with massage techniques, with steroid injections if needed, and sometimes we even have to go back and do a tightening procedure. That's rarer, but in really weak eyelids, it can occur, and although we do everything during surgery to try to prevent it, if it happens after the surgery, we have to go back and fix it, and we can do that safely. We don't charge for doing that kind of thing. I really believe that I want everyone to get a great result that they're happy with, the first time around. If we can't do that the first time around, then we'll do it the second time around for nothing. Lagophthalmos, can't close your eye because too much skin is removed from the upper eyelid. That's happened in very rarely, but I'm super cautious about not taking out too much skin so that we don't have this problem. And worsening of dry eye. If you start off with dry eye, surgery will always cause eyes to become drier because the pump mechanism of the tear function, the tears are pumped across the eyeball by blinking. And if you're swollen, you can't blink as well, and so the pumping is less and the eyes will feel drier. The characteristics of tears also are less hydrating during the healing process, and so it's just something to expect and to treat as needed. So the healing process after any surgery is that swelling peaks on day 2 or 3, bruising will last 7 to 14 days, and then there are predictable phases of healing. Phase 1 is the inflammatory phase of healing. It lasts 2 to 3 weeks, and that's where inflammatory cells are recruited into a wound, and collagen and elastin are deposited rapidly to try to heal the wound, but irregularly. And then phase 2 is contraction, occurs from 3 weeks to 3 months. And that's when the wounds kind of heal in. The collagen and elastin that was deposited goes under contraction so that things can pull in, and this can cause irregularities, it can cause uneven swelling, and that's the time when the eyelids will pull down if there's a tendency for that to happen. And then reorganization is the last phase of healing, where it goes from 3 months to 12 months, and that's where everything is kind of reorganized and wounds soften and settle for their final outcome. What do we do to help healing after blepharoplasty? Well, first of all, with the peels, almost everyone gets a peel. So these are products that we recommend the patients use before and after to help with the healing process. These are just things that we've found have really helped over the years. Elastin regenerating nectar, retinol, and vitamin C are all, by revision, I think, important for healing with peels. Lid lift goggles. Lid lift goggles are these amazing goggles. They're basically like ski goggles, but they have foam on the back of them, so that you wear them and they put pressure in the eye. They're also a bit cooling, so that you don't need to ice, but you do need to leave the goggles on, and we like you to leave the goggles on for 4 days. That pressure really minimizes how much swelling and bruising you get. Patients heal twice as fast, but you can't see through the goggles. So you take them off to go to the bathroom and eat, but for the most part, we like to leave the goggles on as much as possible. And then vitamin K is helpful for bruising. Arnica is helpful for bruising. We like this Mend shake, which is provides nutrients and vitamins that help with the healing, wound healing in general. We have a whole list of dietary recommendations that patients can observe to improve their healing. And then finally, lymphatic massage. So thank you for listening. We're going to get to questions. But what's next? Please follow me on Instagram at Dr. Constantinides. Devin just came on. She is our cosmetic consultant and will contact you by email after this. And you may schedule a complimentary consultation with Devin by replying to that email or by scheduling with her directly online. Or by emailing her at devinw@westlakedermatology.com. You can schedule a paid consultation with me, or you can see Devin, and after you see Devin, if she still has some questions about what you need done, you can have a complimentary consultation, but Devin has to come first for that to happen. And that all happens by calling Devin or calling Westlake Dermatology at Lamar Central, or you can book with me online. I think Devin is going to maybe go through the questions. Devin, would you like to do that?
Yeah, so I had a few questions come in. The first one is in regards to weight loss. So if you're currently going through weight loss and not at your goal, do you need to wait until you're at your goal prior to proceeding with an upper lower blepharoplasty?
Yeah, that's a great question. So it's always best to wait to
Looks like
achieve
you
your weight loss
disappeared.
goal. Am I muted?
No, your screen's off. We
Oh,
can't see you.
you
There
can't
you
see
go.
me.
There you're
Am
back.
I on now? Oh, okay, good.
Yeah,
Perfect. So that's a great question, weight loss. So it's always best to achieve your weight loss goal. Now, as an absolute contraindication to elective surgery, I don't like operating on patients with a BMI greater than 33. So, uh, but if you're trying to lose weight, um, it depends what your BMI is. At around 25, 26, there is enough stabilization of how much fat there is in the midface that further weight loss shouldn't change outcome of surgery very much. However, if you're planning on losing, getting down from a BMI of 30 to a BMI of 20 or 22, then you probably should wait because the what's going on around the eyelid changes dramatically. The eyelid fat doesn't change with weight gain or loss, but the fat around the cheek, how the eyelid transitions to the cheek, what happens to all that is very variable with weight gain and loss. So yes, I'd encourage you to, if possible, wait for your weight loss goals. But if you had a reasonable BMI, you can have surgery and expect a stable outcome.
perfect. What can you not do during the healing process? Exercise, drive, etc.
Yeah, great question. So you're going to be wearing lid lift goggles for 4 days. After that, we like you to wear them at night for the next week or two until the swelling is really down. Most patients can start to get active about a week after surgery. If we've done upper blepharoplasty, that's when the stitches come out, and the peel has healed. The skin is healed over by 7 to 10 days, depending on the depth of the peel. The skin will still be red for several weeks longer. But you can start to exercise. You can start to get more active at a week as long as whatever you're doing isn't causing more swelling. So by 2 weeks, most people are doing some form of workout. To do a real core Pilates and stuff, it's usually 3 to 4 weeks. Head down yoga, inversions, again, 3 to 4 weeks typically. But the rule isn't true for everyone. It just depends on what is going on for you. So if you're paying attention to your body and you're starting to increase your activity level and you're not getting problems, more swelling, more discomfort, whatever, then it's fine to progress. Remember, your vision will be blurry for at least a week after your surgery. So don't expect to sit at home for that week and get a lot of work done. You really want to take a week of healing where you don't have any responsibilities other than taking care of yourself.
All right. What happens if too much skin is removed from the upper or lower lip?
Yeah, eyelids don't, I mean, upper bleph, too much skin out, eyelids don't close. Um, if it's just, if there is, yeah, eyelids don't close. So that's lagophthalmos. You can't close your eyes get dry. It's super hard to fix. Usually requires skin grafting. Lower lid, too much skin removed. First of all, remember, over 90% of my patients, we don't remove any skin. We just create tightening with peels. But too much skin removed, or that will pull the eyelid down, and that will require further surgery to correct. It's really best to avoid these issues, so I'm pretty conservative. I try to be conservative in what I do in surgery to make these issues less of a problem.
Perfect. All right, there's one patient, almost 40, considering a lower and upper blepharoplasty. Will further aging after the bleph lead to the need for additional procedures slash revisions later on, or is this a one and done type of procedure?
Yeah, great question. So at 40, usually you don't have that much going on, right? You have some bags you don't like. You have some heaviness of your upper lid that you'd like to see improved. We're seeing increasing trends to younger and younger patients wanting to get, especially upper blepharoplasty down, where I'm seeing patients in their late 20s who feel like they just want a little bit of excision. Um, so so if you have an up going on that requires surgery, and we do the surgery at 40, probably you will still have some additional skin that becomes lax in the next 20 years of the upper lid, but more likely that any future problems will have to do with brow position because the eyebrows will descend and you'll get hooding or heaviness of the upper lid from brow descent. So that's upper. With lower blepharoplasty, whatever we do to the lower eyelids sort of sets the clock back 15 years. So smoothing things out, make things look better, improve transitions, and then you age. So in another 15, 20 years, you're probably looking at wanting to do something more. However, during that whole time, you'll of course look so much better than you would have that you may or may not wish to do additional surgery. It really depends on the patient. But we don't stop aging process with this surgery. All we're doing is sort of taking care of what's the problem is today, and then you age from there forward.
All right. How soon can you travel after surgery?
2 weeks.
Perfect. How does this compare to Accutite?
No idea. I don't do Accutite. In general, energy tightening procedures are not comparable to what surgery can achieve. I'll just leave it at that.
All right. This one, it looks like they're asking about a timeline between Botox and surgery, if you have to wait a certain amount of time.
Yes. So only if you're if you're considering brow lift, because we know that brow position can be significantly altered with Botox. So we want to see your brows in their natural position to determine whether a brow lift is or is not needed. Having said that, upper lid lacks skin laxity, doesn't change with Botox. You either have it or you don't. Lower lid issues really don't change with Botox. So it's really just brow position.
Perfect. There's another question. They said that they noticed some puffiness or a small pooch under one or both eyes in the before and afters. What causes this? Why do others not have that?
Yeah, so I'd have to go back maybe with you at a consultation to see what you're talking about exactly. But this surgery is not don't think of any plastic surgery as giving a perfect outcome. All we're doing is improving what that patient has as much as we can while still being safe. And so some patients will, just their anatomy dictates that they'll get this kind of an improvement, and yet it won't be perfect. They'll still have some irregularities, they'll still have some puffiness, and we try to talk about all these things before surgery. Obviously, the patients that I've shown are super happy. They've given me permission to put their pictures everywhere, so they're super happy with their outcome. Um, but uh, but we try to be realistic about what kind of results we can deliver. And sometimes you're not going to have you more frequently than not. There'll still be asymmetries. There'll still be some stuff that you'll be seeing that is not perfect, but so much better than it was that people are happy.
All right. And then I have another patient concerned with downturned outer corners of the eyes. Would this be considered ptosis or a brow lift is needed?
Yeah, so a downturn of the upper corners. If you're born that way, that's a syndromic thing that really can't be altered very much. Um, there are surgeries that will specifically lift the corner of the eyelid. Um, uh, Corner of eyelid lifts and can be done, although I tend not to like doing them. They leave the eyelid sometimes looking a little funny. But if the downturn is from heaviness, then usually that's a brow. That's either skin that's extra that's doing it, or brow position that's exaggerating it.
If you've had a history of Bell's palsy, do you have higher surgical risks?
I mean, there are different risks. So not surgical risks, but if you have a history of Bell's palsy and which is for everyone who doesn't know, it's facial paralysis of one side that's temporary and either completely comes back or doesn't completely come back, or it can cause spasm. So if you have a complete return of function with no problems, then you're the same as everyone else. There's no additional risk of surgery. There's no risk that you'll get it again with the stress of surgery. Um, the but if you have spasm or things that are altering the eye on one side or the other, then that's an issue that has to be kind of addressed during examination. So I'd recommend you sort of come in and let me take a look.
Is there anything that makes someone a poor candidate?
I'm sorry, I was coughing. Tell me again.
Is there anything that makes somebody a poor candidate?
There are lots of things. Um, Very sunken cheekbones, so very little support to the eyelid, very little fat in the cheek area, can make the surgery more challenging. Um, Pre-existing severe weakness to the lower lid that can't be overcome with surgery. Previous surgery that's left scarring um, might create might create issues. A severe ptosis or eyelid drooping makes surgery more challenging. So those are the sort of the risks in the area. And then there are some, of course, there are risks related to your general health. We do this surgery under IV sedation anesthesia by at my direction, so we don't typically have to put you to sleep for this surgery. And patients are sedated. You don't really have any memory of anything. But to do that, you have to be pretty healthy. And if you have cardiac issues, arrhythmia problems, other general issues that might put you at risk, we would talk about those during your consultation.
Perfect. Um, does a history of having eczema on the eyelid still allow you to be a candidate for surgery?
That's a great question. I've had recently some patients with eczema on the eyelid, and usually what I do is have you see one of our dermatologists if you don't already have a dermatologist to get good control of the eczema. Then we can do the surgery. The eczema is going to return if it's severe. Um, but should not affect the healings uh, specifically, uh, although it can affect healing along the upper eyelid incision if it's if the eczema is there. So again, good control and good monitor, help from a dermatologist in monitoring that during your healing process, I think are important.
Perfect. Any age limit to have surgery?
Um, so I'm not sure if you're talking about upper or lower limit.
Lower specifically.
So so lower limit. I've done this
Oh,
operation
sorry. No, sorry. I thought you meant eyelid. Upper limit, so patient in their 70s, but for lower
upper
limit.
limit. Sure.
Yeah.
As long as you're healthy enough to have anesthesia, then it's fine to do the surgery. Um, there are some issues with older men, especially with hair loss men, if they need a brow lift. We've done brow lifts on bald men. The incisions are visible, but are much better than having your eyes look so much better that what's going up here is less of an issue for most men have done this on. And the incisions are visible but very well healed, so it's hard to find them. Um, but no, if you're healthy otherwise and can withstand a couple hours of surgery, then you're fine to have surgery. Thank you all for your attention.
Fun.
This video, this webinar will be on the Westlake Dermatology YouTube channel next week. So if you'd like to review what we just talked about, please tune in and follow me.